Adam Lerner, welcome to the New School at Commonweal.
Well, thank you.
Adam, it's a special joy to talk with you. First of all, because you're my brother, and we haven't done a New School conversation before. And secondly, because we've both, from different angles, been working with people with cancer for a very long time. You are a professor of medicine, pathology, and laboratory medicine at Boston University School of Medicine, and a medical oncologist at Boston Medical Center. You got your MD from Yale. You did an internal medicine residency at Boston City Hospital, and you did a fellowship in medical oncology at the Dana Farber Cancer Institute of Harvard Medical School. And you remained there carrying on research in cellular and molecular biology of T lymphocytes. In 1996, you joined the Hematology Oncology Section at Boston Medical Center. Your laboratory research focused on therapeutic potential of cyclic nucleotide phosphodiesterase, if I'm saying that correctly, inhibitors in lymphoid malignancies, and the mechanism by which a novel adopter protein modulates focal adhesion complex signaling in a number of kinds of unpronounceable cells. And your expertise includes chronic lymphocyte, includes leukemia, lymphoma, sarcoma, and skin cancer. Have I gotten any of that wrong?
No, that summarizes it.
Right. When did you start practicing cancer medicine, Adam? How long ago?
Well, as you said, I went on faculty at Boston Medical Center back in '96, and my training in oncology started a good 8 years or so before that. So I've been at it since the late '80s.
Right. So my first question for you is, in your years of practicing cancer medicine, what are the greatest changes for the better that you have seen in your ability to treat cancer?
Yeah. So yeah, when I first started, there were a few cancers that we had a significant positive impact on, and treatments involved varying combinations of a few often plant-based compounds that block the proliferation of cells. These various drugs that damage DNA or in other ways cause cancer cell death, but that are really quite nonspecific. That certainly had quite a lot of toxicity and acted on normal cells as well as cancer cells. And when I look around at the medical oncologists that are in training at Boston Medical Center now, I'm impressed and intimidated by just how many different medications, classes of medications, an oncologist now uses. The number is easily 10 times as many as when I was in training, but they've also changed, fundamentally in their mechanisms, rather than being fairly non-specific inhibitors of basic cellular processes like cell division or damaging DNA. They're now often quite targeted, so inhibiting very, very specifically inhibiting enzymes that are uniquely important to certain malignancies. So these are the so-called targeted therapies. And there's just a large number of these that is growing every year. And then, as you and I have discussed, the other exciting new class of drugs are modulators of the immune system. And that has, profoundly changed the outcome for a number of cancers for the better. Giving treatments that are remarkably more effective than they used to be, and often quite well tolerated relative to those sorts of therapies that we used many years ago. So that was a long-winded answer, but I think the point being that I think patients' experience of going through treatment, while still not an easy one, has improved over time, and the efficacy of therapy has also improved for many cancers. Certainly not all of them, but for many.
We'll come back to that line of questioning, but Boston Medical Center is a famous and storied cancer center in Boston. My friend and colleague Ted Shetler was on the faculty there, as you are. You treat a great many of the low-income residents of Boston. Is that correct?
Yeah.
So in your practice, when you look at the people who come for cancer treatment, if you were to do a socioeconomic and ethnic distribution, how many of them would you say are low income? Let's just start there.
Yeah, a good large number. I'd say certainly more than half.
Mm. And in terms of the ethnicities that you see, can you give me a rough sense of who you treat?
Yeah, a real wonderful polyglot of people from all over the world. Many Black patients, many Latinx patients, but also just a range of folks from all over. Many that are recent immigrants to the U.S. So makes for a wonderful experience as a physician, just in terms of getting a sense for the full range of humanity and the different lives that people live, often from out of the United States, but also certainly challenging in terms of language, and challenging in terms of just where people are coming from. I think it's often hard for the physician to really appreciate where folks are coming from, and I get repeatedly surprised by the personal histories of our immigrant patients in particular.
When you said Black and Latinx and then from all over, but if you zeroed in a bit on all over, what are the populations of all over that stand out in terms of who you see?
Yeah. We have many Cape Verdean patients. So that's a common group. Many Haitians, groups from some parts of Europe, Albanians, Cambodians, Vietnamese, folks from South America, quite a number of Brazilians. Just a full range.
Coming back to the question that we started with about what you have seen that is better, could we drill down into what are the cancers where you've seen the most dramatic improvements to start with? What in other words, you've talked broadly about the fact that some cancers are that the treatments are much more targeted and better tolerated in many respects. But where are the cancers where it's been quite remarkable?
Well, I think the winner for that line of thought would be melanoma, without question. As just by happenstance, I picked up the care of patients with melanoma soon after I arrived at BMC in the late 90s. And the major forms of treatment were various pretty toxic chemotherapy regimens, but also some immune therapies, particularly the use of interferon and also high-dose interleukin-2. And we, to look back on it, we were doing it with the best of intent, but I think the balance of toxicity and efficacy was terrible. These treatments were really hard on people, and they had really fairly little effect on what is, when the melanoma is advanced, it is frequently a mortal illness. And it's a very aggressive illness, melanoma. So it was just one of the most, profoundly challenging jobs you could ask for as an oncologist to care for people with metastatic melanoma. Interestingly, both melanoma and another skin cancer, cutaneous squamous cell carcinoma, are different from other cancers in that they're both unique in having many mutations in the genes of the cancer cells that are the result of exposure to sunlight. These are both skin cancers. So you're only going to get, sunlight-associated DNA damage in skin malignancies. And the interesting thing about that is that if you look at the total number of mutations that occur in these cancers, they're significantly higher than for other forms of cancer. So we talk about the somatic mutation burden. So that's the number of mutations per megabase, per million bases of DNA. And they're markedly higher for both cutaneous squamous cell carcinoma, which is a pretty common kind of cancer, and for melanoma. And the reason that's important is that the immune system really is capable of seeing cells that are different from other cells when they see a mutated protein presented on the surface of the cell through these major histocompatibility antigens, which are basically proteins that stick a little piece of a protein out on the surface of the cell to be looked at by the immune system. So the immune system is constantly sort of patrolling your body and looking for trouble. It's probably largely derived from looking for viruses, but it probably also evolved to look for cancer cells. Now, the cancer cells, when they're recognized by the immune system, particularly by T cells, they can be killed by those T cells when the T cells detect an abnormal protein. And so probably this is going on all the time in our body, unbeknownst to us, that we're being protected against early cancer cell progenitors by our T cells. However, with time, as is generally true of cancer, these things evolve. There's sort of a Darwinian evolution that's going on in cancer cells. And what they learn to do is to protect themselves against this immune system monitoring by overexpressing proteins on the surface of the cancer cells that are basically like a stop sign for the immune system. They put up a big stop sign and say, you're not interested in me. There's nothing going on here. Please move along. I think the enormous breakthrough recently in oncology, for which there was a Nobel Prize awarded, was the recognition that whereas for many years the thought was that there was not sufficient immune signal there from the cancer cells, and that we really needed to provide a better sign that the cancer cells were abnormal by giving cancer vaccines or things like that, or more immune system hormones like the interferon that I mentioned. Instead, the real change in thinking was that what was holding back our own body's ability to respond and fight developing cancers or well-established cancers was to block this negative signals that are provided by these cancer cells, to somehow stop the cancer from putting up these stop signals that I mentioned, cover up those stop signals. That's really turning the whole paradigm of what is therapeutically useful on its head. Instead of there not being enough of a signal, there's plenty of signal in many cancer cells. There are plenty of abnormal proteins being expressed on their surface. The problem is that, again, you need to develop drugs that allow the T cells to do what they can do, and not to be blocked by this negative signaling. So the two molecules that have come into major play in treatment of cancer patients are two molecules called CTLA-4 and PD-1. The first one that was identified was a cell surface molecule called CTLA-4 that turned off the immune system. The drug companies made antibodies against CTLA-4 that covered up that negative signal. And they immediately started seeing responses in patients with melanoma. Quite a bit of toxicity from that treatment. But really the first demonstration that this sort of approach to immune therapy was going to have success. And for my generation of oncologists, it was a profound moment to start reading these first clinical reports, because there'd always been a promise that the immune system could be harnessed to treat cancer, but it never fulfilled its apparent promise. And despite decades of work with, as I mentioned, cancer vaccines, taking various cancer cell lines and vaccinating patients with them, making lots of T cells and infusing them into patients. It always seemed like something that was on the brink of being successful, but never really had a big impact on an illness like melanoma. So CTLA-4 antibodies against CTLA-4 were the first, and then the big change came with targeting this drug, this cell surface antibody called PD1, which is a protein that's expressed on T cells, and PDL1 is expressed. Its partner, its ligand, is expressed on the melanoma cells. So they developed antibodies against PD1 on the T cells, covering up this sort of stop sign that I mentioned. And this one was a combination of considerably more efficacious and generally very well tolerated by patients, and really moved the curve on the fraction of patients, sometimes with very advanced melanoma, that were being essentially cured by this treatment. So the current data on this sort of therapy, to get down to the details of it, is that during the era that I first trained in treating melanoma, the 5-year survival for patients with advanced melanoma was less than 5%. There was a recent report that had extended follow-up for patients that were treated with both anti-CTLA-4 and anti-PD1 who had advanced, usually metastatic melanoma. The 5-year survival was over 50% at this point. Remarkable. So, I feel very fortunate to have watched that transformation of this miserable disease. It's you can imagine it's a profound experience for the patient and the caregiver to give treatment that allows a patient's immune system to wake up and start fighting this cancer, and sometimes to see just really traumatic and lasting responses. I can't oversell this sort of approach. There's still about 50% of patients with melanoma who are not ultimately surviving their disease. So there's very much room for continued improvement. And I also wouldn't want to say that, these treatments are completely without potential toxicity. Some patients seem to get through it with relatively minor toxicity. Others can have some pretty significant side effects. The type of side effects from this treatment are very different than from ordinary chemotherapy. They are these autoimmune responses. So you basically now made the body's immune system sort of on a hair trigger, and it can become confused and attack normal cells in the body instead of the cancer cells. So people get autoimmune thyroiditis. They can get autoimmune attack of other glands in the body, like the pituitary gland, leading to cortisol deficiency. They can get rashes. They can get joint pain. They can sometimes get autoimmune lung involvement or colitis, diarrhea from colitis. generally speaking, if you get these autoimmune side effects, they can be fairly promptly managed by giving steroids. And generally speaking, people get through this treatment safely and without too much in the way of side effects. So I think the efficacy to toxicity ratio is pretty terrific overall. But I think everyone needs to go into this kind of treatment understanding that it's always hard to predict in an individual exactly what they're going to be facing.
Thank you, Adam, for that. Let me step back to the larger picture, just from American Cancer Society data and other sources, ASCO and World Cancer data. I read that cancer mortality rates in the US have declined by 29% since the 1990s, driven by progress against lung cancer, which has an awful lot to do with people stopping smoking, right? So that's a big driver. The 5-year survival rate has increased 17% between 1970 and 2013. And that is attributed to earlier detection and advances in treatment. And I well imagine people stopping smoking. Cancer death rates are falling. The declining rates are driven by long-term drops in death rates for lung, colorectal, breast, and prostate cancer. Then, as you said, declining death rates from melanoma reflect new treatments approved in 2011. And then improvements in other treatment protocols, including leukemias and lymphomas, are due again to targeted therapies. But the studies go on to say that a 2018 review showed that less than 5% of cancer patients benefited from genome-driven cancer therapies that target aberrations on tumor cells, and that the percent of patients with cancer that benefited from genome-targeted therapy in 2006 was 0.70%, and by 2018, it had increased to 4.90%. So basically, big improvement, huge improvement, but applies to less than 5% of all cancers. Would you add anything or correct anything that I've said there?
Yeah, no, I think that I'm quite aware of the data about the promise of targeted therapy versus the reality of how many people end up with an actionable target identified and then actually find that the targeted therapy was of clinical benefit to them. And it is still a small number. I guess that much of the care for the most common cancers, lung cancer, colon cancer, breast cancer, there have been definite incremental advances in the treatment of all of these tumors. But I would say the majority of it is not necessarily these targeted treatments that you've just mentioned. That's the genome-driven targeting. Without question, if you have a lung cancer, one of the very first steps you're going to do is you want to make sure that you have all the molecular information that you can about that cancer. And some of the in some cases, you do identify mutations that are treatable with targeted treatments, often reasonably well tolerated and can be efficacious. So I think we're all in favor of doing that testing, but the bulk of the treatment of these cancers still remains, to a large extent, a variety of treatment regimens that are not necessarily based on that sort of genomic testing. And I also, I think any oncologist has to remain pretty humble about, the difficulty in curing a lot of these common epithelial malignancies. There's progress, and people live longer than they used to, but you need to remain pretty clear that the progress is not as much as we would hope for.
So if I
I also think it's the last thing to say about that is it's just changing every year. So data from 2006 or 2010 is data different from data from 2021. I think, there are newer and better targeted therapies coming up for many of these malignancies every year. They're not usually a cure. They're things that prolong survival, sometimes are reasonably well tolerated. So I think they're important, and they'll continue to be more and more important over time. But we just can't oversell what they're accomplishing right now.
So if I were trying to summarize what we've said so far, the targeted therapies have been dramatically effective in melanoma and important in lymphomas and leukemias, but the number of people with those cancers who benefit, at least from the data that I had here, which may be earlier, was around 5% of all cancers, but nonetheless enormously important for the people who have it. But for the common epithelial cancers, colon, prostate, breast, lung, and so on, progress has been less than we would have hoped. The management improves. As you said, sometimes you can do testing and find common cancers where you can do targeted therapies. It makes an awful lot of sense to do that testing. But overall, the common cancers have proven pretty recalcitrant to what we've done so far.
Yeah, I mean, the only correction I'd make is just about the language we use for these different types of treatment. So when I went on and on about melanoma, so that's immunotherapy. It's called checkpoint inhibitor therapy. That's not a targeted therapy. That's harnessing the immune system. It's just, it's nomenclature. The word targeted therapy typically refers to the use of drugs that are against a particular enzyme, inhibit a particular enzyme that is uniquely important, maybe not uniquely, but that is important in subsets of cancers, not all cancers. So often, a particular cancer will have frequent mutations in one enzyme. And the drug companies develop a good inhibitor of that enzyme, and that leads to clinical responses. And that's the sort of thing that one looks for when one does next generation sequencing of the DNA of the tumor and look at hundreds and hundreds and hundreds of genes to see which of those commonly mutated genes in cancer is mutated in that particular individual's cancer, and therefore one could use that particular targeted treatment. But, the other thing to say about the common malignancies, I said there's incremental improvement in outcomes. And I think it's quite important. Like both breast cancer and prostate cancer are hormonally sensitive in many cases, but not all cases. So I don't know what you want to call it. It's hormonal therapy, and there's been, again, important incremental improvement in the treatment for these tumors over the last decades. And people are living longer than they used to. There are also, the other big class of therapeutics in cancer are just generally antibody therapies, frequently against proteins that are growth factor receptors on these epithelial malignancies. So in breast cancer and other epithelial malignancies, those sort of antibody therapies have been an important incremental advance. I could go on and on. I think the fact is we see patients that with, a range of these different therapeutics in a skilled oncologist's hands are living certainly longer than was the case when I first started.
And that's so important.
Yeah.
I saw a study recently that really caught my eye, and I don't have the citation here. You might have seen it, that for many women over 70 with breast cancer, that I don't know quite how to describe it, but it was basically that non-treatment with aggressive therapies was as effective as treatment with the aggressive therapies. Now, I don't know. I assume that meant that the women who were untreated with aggressive therapies were getting hormonal therapies, but I don't know that. Do you happen to know that study or not?
I don't. Yeah. Okay. I don't. Yeah.
But it's in line with, or let me ask you it as a question. If you see a woman over 70 with breast cancer, I'm sure it depends on the specifics, but is hormonal management as opposed to chemosurgery and radiation something that comes to mind?
Yeah, as you said, it's just completely dependent on the specifics of that breast cancer.
I'd have to study.
There are the estrogen and progesterone receptor positive cancers are hormonally responsive, and frequently, one might. It would also depend on just the clinical stage of the breast cancer. So I think it's a little hard to generalize. I think the overall point you're making that sometimes more is not better, particularly in the elderly, is absolutely, accepted by the oncologic community. There's, as I think there's a whole field now of geriatric oncology, which is focusing on, amongst different people of different chronologic age and physiologic age, how do you make the choices of whether to treat, and if so, with how much? And it's getting to the point where, we not only talk about, are you going to give 100% of the dose you might give a younger person, 50% or 75%? They're really, certainly in hematologic malignancies, a lot of discussion about how you go about choosing the right intensity of therapy. Mm-hmm. And it very much depends on the particular cancer, in addition to all the specifics about the person in front of you in terms of their physiologic reserve, not just how chronologically old they are, but your best estimate as to their functional status and their ability to tolerate different kinds of treatment. There are some malignancies for which, cure is under normal circumstances the goal. And so cutting way back on treatment simply because of somebody's chronologic age might not be the right choice. On the other hand, we've learned that, I'll take lymphoma as an example. You take a curable lymphoma like diffuse large B-cell lymphoma. It used to be that we sort of gave the same treatment to everybody, regardless of age. And now we know that you can cut the doses essentially in half for patients over the age of 80, particularly if they're relatively frail, and have really good outcomes with that reduced intensity, that they can tolerate the treatment, and they seem to get lasting benefit from it. So, yeah, there's a lot of interest in what's the right amount for people at different age.
Mm-hmm. Of course, that a lot of our interest focuses on integrative therapies. I mean, we are tremendous believers in the skillful use of conventional therapies, as you know, in our work. And I regard the ASCO-sponsored website, cancer.net, as perhaps one of the best resources for patients in terms of being constantly updated. So let me just start with that question. When you have patients who want to learn about their cancer, what website do you refer them to?
To be completely honest, I don't do a lot of that, and it may have something to do with the patient population that I'm dealing with, for whom English is often not their first language, and many of whom are not using the internet a great deal. Mm-hmm. I think, my practice is a little bit unusual in that respect, and I'm aware that there are multiple excellent sources of information out on the web, including, I think, Commonweal offers quite a bit. But I think it's a great idea to refer people to the right source. And again, I think it's just something special about my practice.
Yeah. Let me go to prostate cancer for a moment. As you know, my friend and colleague, Dean Ornish, has done a lot of work on integrative therapies to reverse coronary artery disease and diet, exercise, stress reduction, and social support. And he then applied that, among other things, to prostate cancer. And in his studies, found that early stage prostate cancer patients with a relatively low Gleason index that he saw in his controlled studies outcomes that were at least as good as more aggressive treatment. Then there's been kind of a debate in the medical literature more broadly, as I've read it, about whether wait and watch with prostate cancer, leaving aside integrative therapies to improve your health while you do wait and watch, whether wait and watch is actually a legitimate option. Do you follow that field enough to have a view on it?
I'm not a GU oncologist. Prostate cancer is not my usual, the thing that I'm generally seeing people for or giving advice. So I'd have to be fairly careful about it. My own personal feeling about it is that I think the whole field has moved a bit towards greater adoption of watch and wait. Prostate cancer is a tough malignancy in that many of the earliest tumors that are low grade may never be of clinical significance to that patient. If you were to go out and biopsy every man over the age of 70, over the age of 80, over the age of 90, you're going to see enormous numbers of prostate cancers that most likely would not be responsible for the death of that patient if left alone. On the other hand, there are prostate cancers that are, quite aggressive and do shorten people's lives. They are often tumors that might have already progressed by the time the patient is diagnosed. And so the question is, how many patients do we hit that sweet spot where we can identify somebody who's going to go on to have disease that will be clinically important in the years ahead of them, and that by aggressive local therapy with surgery and radiation, you can arrest that process? What is the fraction of such patients where you've found just that group where it was an important cancer that would affect that person's life, but it hasn't spread yet? And I think the big randomized trials would suggest that that's probably a pretty small percentage of the total population of people with prostate cancer. So it makes it very hard for us to have a really major impact on survival with aggressive surgery and radiation. But again, as you said, it's a controversial topic. And I think it isn't, completely my area. So I wouldn't say anything definitive about it. I certainly think that for some people who have apparently localized disease with a higher Gleason score, that it's reasonable to get surgery and radiation.
Is the Gleason index, this is ignorance, but is it a good marker of the aggressiveness of prostate cancer, or are there better markers?
So it's essentially what the pathologist grades the cancer as in terms of various malignant features. And it is, I believe, critically important to prognosis. Mm-hmm. I guess what you're asking is, are there are a lot of questions wrapped up in that question. How reproducible is it? Mm-hmm. If you take the same prostate biopsy and you show it to 20 pathologists, how reproducible will the Gleason score be? And how much, as you say, what additional biomarkers might there be that would help in a decision? To my knowledge, the Gleason score remains, the most important single factor.
We were just speaking of reading pathology reports. In my understanding, which has been affirmed by leading people in the cancer community that I know, that the reading of pathology reports is a critical link in the chain, that if the pathology report is read differently, you might get a different treatment in some cases. And that there are some centers where when they go over it, that the error rate in pathology reports is much higher than at other centers. Does that make sense to you?
Yeah, I mean, I think from my own personal experience, I've run across cases where diagnoses have changed with review. So I do think that particularly for some subtypes of cancer that are challenging for the pathologist, that it's reasonable to get other sets of eyes on it and get other opinions. Whether the other opinions are always better than the first opinion, I mean, having watched this process a few times, I think it's not always clear that the consultant, gives a better answer than the original diagnosis. Depends, obviously, a lot on which institution you're at, and also, the particulars of the malignant process that you're looking at. I think that many pathologists are actually quite comfortable with sending out their more challenging cases for review elsewhere. And it's just the right thing to do. So it's certainly something for a patient to be aware of, that, in certain instances, it may be good to request that your pathology be reviewed by another institution, for instance.
And are there specific malignancies? Let's just take breast cancer, for example. And again, you are so much more expert in all this than I am by light years. But it seems to me that I may have read that in breast cancer, you can get different readings from different biopsies of the same breast cancer. Is that accurate or not?
I'm sure that's true. Okay. Yeah. I'm sure that you may get, you can get variation from one part of a tumor to another. Yeah. So how frequently that makes sense to do a different...
So if that's the case...
Yeah. Go ahead.
So if one were trying to optimize care, obviously optimizing care is a luxury anywhere, but if one's trying to optimize care, what are the malignancies where the differences in reading, whether from one pathologist to another or one biopsy to another, are sufficiently important because of the differences in treatment and outcome that one would be more inclined to get another set of eyes on it?
Yeah, so there are two different questions here. One was about two sets of eyes. One was about two sets of biopsies.
Yes, exactly.
So, it's hard to paint with too broad a brush. I do think hematologic malignancies, lymphomas, are often challenging. There are a lot of different diagnoses within the non-Hodgkin's lymphoma category, and they have different treatment paradigms. Furthermore, so that's to say that in some instances, it really, for challenging cases, it's quite appropriate to get a second set of eyes. And as I've mentioned frequently, the pathologists will be the ones that will do it even before it's requested. But in terms of getting other biopsies, that comes up with, it's not super frequent, but there are malignancies that are relatively low grade, meaning they don't proliferate very quickly. Their natural history spreads out over years. They may not need immediate treatment. That can undergo molecular evolution and transformation to higher grade malignancies. And that would be clinically very important because those would be treated differently. And so if you do a biopsy and because you maybe didn't use every resource at hand to identify the highest grade area of someone's malignancy, you may essentially not appreciate that the patient has a more aggressive, a more high-grade malignancy than was apparent from the biopsy that was done. So we do use some radiologic imaging techniques to try to guide what's the best site for biopsy, particularly in lymphomas. There are these PET scans that I think you're familiar with that are like a regular CAT scan, but then in addition, they use the fact that cancers take up glucose and that the more aggressive and proliferative cancers take up more glucose. So you can actually guide the site of the biopsy by choosing to look at areas that have the highest glucose uptake, so that if you had somebody who had an underlying indolent, slow-growing lymphoma, but that had transformed at one site, then maybe being guided by PET would allow you to see a higher grade. You know, how frequently it actually works out that that's tremendously successful, I don't think in every case that you definitely would change your diagnosis by PET-guided biopsies, but it is something that people do and think about.
Let me ask you about another subject, which is to what degree, again, this is in ignorance, but to what degree standard of care, in quotes, guides an oncologist's decisions, and whether, for example, an experienced oncologist who may be seeing better results and reading the literature according to his or her lights, might want to deviate from a standard of care. And I guess, I mean, obviously we live in a very litigious society, and also institutions have to guarantee quality standard of care. I'm just asking, is there a tension between an oncologist's knowledge and intuition about what best suits a specific patient and whether there's any pressure to adhere to standards of care?
Yeah, that's a really good question. So I think you know that you can go to the NCCN and download these flow diagrams for the management of most cancers.
NCCN being what?
The National Comprehensive Cancer Network.
Okay, thank you.
Yeah, so you can look up, non-Hodgkin's lymphoma of various types and look at what is considered the standard of care. You're right, there is a tension in the field of treatment for these cancers does evolve pretty quickly, and there can be a gap between the latest hot treatment that's just been published, maybe in somewhat preliminary form, but, looks really encouraging and uses maybe medications that are already familiar and FDA approved for another indication, where the oncologist may choose to treat with something that they've seen more preliminary data, that looks really promising, or maybe they've had the experience already themselves that something's working, and utilize that rather than the precise step in NCCN. I think that's got to be a minority of such cases. I think it also depends, again, entirely on the cancer type. There are going to be cancers for which, generally speaking, lots of things don't work particularly well, and you're trying to give palliative treatment to extend someone's life and to ameliorate symptoms, and you have many different options to choose from, and they're not really all listed in NCCN. And what happens is that the practitioner will, either from their own experience, or they'll call up their buddy at another institution that sees a large volume of these unusual cancers and try to get their best advice about, what they've seen and what works. And, I think that ends up actually being a pretty significant portion of overall cancer care is not captured by, as you put it, the sort of standard of care treatment, diagrams, because, often plans A, B, and C don't work, but the patient is still doing okay, and you're just trying to find something that, will help. And you're going more on, modest phase 2 data or things like that, rather than really well-established big phase 3 trials. A lot of cancer, the numbers of patients for some of the less common cancers are small enough that there isn't wonderful phase 3 data for every treatment choice. So there's quite a bit of that I think that goes on.
This goes back to a subject we talked about earlier, related to wait and watch or less, less aggressive treatments with the elderly. But it has to do with the growth of palliative care as a specialty. I've seen some studies of some cancers where patients on palliative care actually lived longer than patients on active treatment.
Yep, that's well established.
That's well established. Okay. So and I also hear some palliative care enthusiasts say that it's sometimes that palliative care can be begun as early as one wants. It doesn't have to be end of life because it's quality of life issues. So the question for you is, as you have practiced over the years, has palliative care been an area of growth? And how does it intersect with your practice and the practice of cancer medicine?
Yeah, I mean, it's definitely grown without question. I think it's got to depend on the particular oncologist. I mean, you could argue that a good oncologist should know a good bit about palliative care themselves. But I lean on my palliative care specialists at the hospital quite a bit. Mm-hmm. There's certainly things that they do better than I do about, sophisticated pain control and things like that, where I will turn to them for help. And then I agree with what you just said, which is that it's not an either or issue. I think that having someone whose focus is on quality of life and ameliorating symptoms be seeing a patient and doing everything they can to accomplish those goals doesn't mean that there can't be somebody who's wearing a different hat, which is focusing primarily on, keeping this malignancy from growing and trying to find some kind of regimen that will shrink it, et cetera. Those two jobs can be managed by one person or one team. and I think they frequently are, but under ideal circumstances, I think it's great to have both practitioners involved in the care of the patient at the same time. Yeah.
I want to ask you about the cost of standard care. The data I've seen is that 42% of patients deplete their life savings. Obviously, these $92,000 within 2 years of diagnosis. And also that in 2015, research showed that in the previous decade, the average monthly cost of cancer treatment more than doubled to $10,000. Obviously, you treat largely a very low income community. So presumably they are on, or many of them are on public insurance of one kind or another. But what is your observation over the course of your career on the cost of cancer therapy?
Yeah, I mean, some people have pointed out that for many patients, the cancer is not the biggest problem in their life.
Right.
There are a lot of other things going on that are actually of more immediate consequence to them. Do they have a house over their head? And do they, what's going on with their family and their loved ones? And that happens a lot in our practice, that we have to try to be sensitive to all the other things that are going on in a patient's life besides the cancer, and how they make choices, as they go along about which is more important. And in terms of financial impact of having a cancer diagnosis, it may not be out-of-pocket costs for the medications, although I think that's maybe what you're driving at, and certainly that can be a big issue. To some extent, that's in a safety net hospital. We have some resources that help in that. We can get medications somewhat less expensively for our patients, but it remains a big issue. And I think that the other big issues that are financial are not about the cost of the medication, but about not being able to work. About having other family members that have to take time off of work in order to care for someone who's going through cancer treatment. There are just many, many things that I think can impact one's financial health, other than out-of-pocket costs, even though the out-of-pocket costs can be quite important. So the cost of cancer care has grown extraordinarily. It's a difficult topic because I think none of us feel comfortable trying to put a dollar amount on, what someone's, quality of life is worth, what their survival is worth, and what their sense of hope is worth. If you may have a medication that's not certain to work, that may be very expensive, but might work. And it's awfully painful if that approach is held up for financial reasons. So the end result is that given the way the United States healthcare system works, the costs of care in the United States are extraordinary, and cancer makes up a pretty big piece of that. It's certainly not the only issue, but it's an important one. And as you've been pointing out with some of your public health statistics that I think are so important to keep turning back to, the amount of increased survival we get per money spent is not impressive. We spend tremendous amounts of money, and we don't necessarily push the curve for survival anywhere near as much as we would like. However, the other side of the coin is that, we have a a pharmaceutical industry in the United States that periodically you just have to, at least I personally just am dumbfounded by the amount of skill and cleverness with which these companies come up with drugs that are really important advances for the patients that have these illnesses. They may not be, the most common lung cancer or colon cancer cases, but for the patients that have these illnesses, these new drugs are remarkable. Are they worth, $100, $200, $300,000 a year? Because the numbers can start to be extraordinary. No, I wish we had a system that that somehow managed to make a sensible financial model for costs of cancer care. That's going to be very difficult to accomplish. I think one other issue that we don't talk about a lot is just how variable what can be offered to patients is around the country. If you get cancer in one state or one city versus another state, in a rural area versus an urban area, and what your insurance options are, will have a big impact on whether you have access to some of these new medications that can really make a big difference for you. And this is just getting to be a bigger and bigger topic every year. We're now starting to use with some frequency this chimeric antigen receptor T-cell therapy. I think you've heard about that. These are these genetically engineered autologous T-cells. So you take the patient's own T-cells, you infect them with a virus that results in the expression of a chimeric artificial receptor on their surface that is specific for the cancer. And these can be, profoundly effective in patients that have no other option for treatment, but at fantastic cost. It's now been approved by Medicare, so it's actually, an approved treatment, but it's just one more example of how the cost curve keeps moving up and up and up. So I have no solution for this, but I do think the overall system is pretty broken in the United States as a whole. It's not a sustainable system for sure.
It's such a quandary because if you look at COVID, what is the country that came up with the better vaccines in a short period of time compared to Europe or anywhere else? It was the United States, right? And so, here's a situation where, the capacity to bring those vaccines online that fast. Obviously there have been hiccups and problems and this, that, and the other. But nonetheless, the vaccines are an extraordinary accomplishment compared to how long it usually takes to get a vaccine.
Yeah.
So it was unbelievable. So I completely agree with you that it's a deep quandary. The countries that have, publicly sponsored healthcare systems are not the countries that came up with these vaccines for the most part. So it really is a question. But along those lines, a subject we've occasionally discussed also, and let me ask the question based on my ignorance again. I understand that for many cancers, there are generic drugs that have been around for a long time that sometimes have outcomes as good as the new drugs that are coming on. And yet, because of the way the financial incentives work, you can have shortages of the generic drugs, which are less expensive, because the financial incentives push the industry and other players to use the new ones. Is that accurate?
Yeah, I think it is a problem. an important one. I don't think I would overstate it. I think, generally speaking, we have access to the older off-patent medications. But it's periodically a problem to get these drugs. And when it is, it does really make you want to bang your head against the wall because, as you said, they're often logs, on tenfold or 100-fold less expensive than newer medications, and they have an established track record, and we know how to use them, and we've been using them for years, and sometimes, absolutely because of market forces, there's a national shortage of some of these things. Mm-hmm. So without question, how much money a company makes off of these drugs has an impact on how much of it's around to be sold. Mm-hmm. I think, there have been efforts to try to come up with a new financial model to support the makers of generics, so that it's sustainable over time. It hasn't been solved yet, and it's true for actually, I think, many, not just drugs. There are other things within overall medical care that are essentially low-cost things that there's just not a big enough profit margin for them, and we do run into these shortages. Yeah, it's. I think that the intersection between capitalism and medicine is a messy one, and trying to, organize a system that is fair to all parties involved is difficult. And I think it's easy to berate the pharmaceutical industry, and I think sometimes it's definitely deserved. But as you just said, sometimes, we have to recognize their worth in this whole process. And frequently the products that are being made by these pharmaceutical firms are extraordinary and really having a big impact on people's lives. So how exactly to value that, come up with a system that is fair for the consumer and for the firms that are making this. It's tough, and they haven't figured it out yet.
It's also just true of American culture as a whole. I mean, we are a very entrepreneurial culture that doesn't put a high value on safety nets. And so many European countries and elsewhere have much stronger safety nets, but are nowhere near as entrepreneurial, not only in medicine, but just across the whole range of inventiveness. So it creates a very dynamic society that creates all kinds of new and promising things, but the benefits are less equitably distributed than in other countries.
Right.
I want to ask you about bias in research. I've been looking at this question, and there seem to be a set of different sources of bias. Sponsorship bias, the tendency of studies to show outcomes favorable to the sponsors, reviewer bias, publication bias, researchers and their financial sponsors may be less likely to publish a study that shows no effect, and so on. Reporting bias, studies that show an effect of something that is going to be very profitable may be more touted both in the public literature and in medical sources and so forth. There was a 2019 article in JAMA Oncology that found that 16% of anti-cancer drug approvals in the U.S. included a comparison group not sufficiently well designed to make sound conclusions about the superiority of the experimental treatment correct. And so my question to you is, when you as a clinician and scientist read the literature, to what degree do you have a sense that what you're reading is actually reflective of where a more comprehensive view of the science would take you? And to what degree does it introduce a certain agnosticism?
Well, I think it's a good segue from the last subject we were talking about, in the sense that, again, with the intersection of business and medicine is a messy one. Many of the trials that are being carried out, the big randomized trials, are underwritten and run essentially by the companies that are developing a new drug and that are going to make a large profit if their drug is ultimately found to be superior to the comparator and become FDA approved. So the comment you made about, what is the comparator and is it the appropriate comparator, is, I think, something that many oncologists pick up on all the time. What is a reasonable, if you've got a new drug X and you're comparing it against current standard of care for the illness in question, what are you going to pick as that standard of care? And often, there's some debate as to what might be that standard of care. And it often feels as if the comparator that's being chosen is not the first one that any of us would choose. It's not the most effective. It's not the drug that, or the regimen that we would feel would be the one we would currently go to for that particular situation. It might be a somewhat older regimen or a somewhat less aggressive regimen, but maybe one that is still, as I mentioned, within the NCCN guidelines or out there as a possibility. So the end result is that, you're choosing what's the metaphor, a paper tiger? Or you choose something that's pretty easy to knock down, and then you knock it down with your randomized trial, and your drug is accepted. So I think that's not uncommon. And more generally speaking, I think, particularly as you get older in this business, you do have a somewhat jaundiced view of a lot of the newest therapies that things often look to be, look in these trials to be better than they actually in the long term will prove to be. It seems as if a lot of new regimens have, marginal improved efficacy and pretty substantial toxicity. So, as an example, some of the newest drugs in treatment of myeloma, there's some substantial toxicity, and then the increments in outcome are modest. But on the other hand, I think we generally want to encourage clinical investigators and companies to be as creative and inventive about the introduction of entirely new classes of drugs. And as a whole, I think the enterprise of clinical studies in oncology is still, I don't feel it's broken. I think it's good that it's held to the standards that it is. I mean, I think trying to get FDA approval for a new oncology drug is still a pretty high bar. You have to prove that your drug is efficacious and going to add value to the range of options that are available for the care of that illness. So I guess it just depends on what you want to focus on. Is there bias in clinical trials? Yeah, I think all of us recognize that there is, a strong commercial drive that is underwriting a lot of the clinical trials that are out there today. So you have to read what you're reading with that in the back of your mind. But where would we be without, these companies making these new medications with profit in mind? We would not have this whole, generation of new therapies out, many of which are extraordinary. So within our own academic circle, it's actually a topic that, we often talk with the hematology oncology fellows that are in training, that it's important to look at trials with a little bit of a jaundiced eye, and keep in mind that things are being put in the most positive light possible when those articles are written.
Let me go from there, which is clearly about the pharmaceutical industry and its underwriting of research. They and others have also managed to structure the whole system so that there are financial conflicts for oncologists and institutions built into the system. So, for example, in Medicare reimbursement, drugs that are administered by infusion and injection in physician offices and outpatient departments are covered by Medicare B. And in the US, Medicare reimburses cost on the basis of average sales price plus 6%. This means the provider will be paid more for prescribing a more costly medication. That's from Medscape 2018. Beyond the reimbursement incentive, a study in 2018 showed that some oncologists may be more likely to prescribe certain cancer medicines when they receive payments from the companies making these drugs. And a review of prescription practices in 2 types of cancer for which several treatment options are available compared to physicians who didn't receive any treatments to those who did. And they were 84% more likely to prescribe a treatment for renal cancer medication and 31% more likely for a medication for chronic myeloid leukemia. So again, I don't see any blame in these things, but what I'm doing here is to go through the research that we've pulled together and just check it against your lengthy experience in this work. Do those kinds of conflicts rise to the level of awareness or concern?
Yeah, I mean, I think my practice is very atypical for reflecting the practice of oncology in the United States as a whole. I'm in my ivory tower, and I'm largely sort of, how should I put it? I'm protected against against all of this. We are salaried physicians that aren't particularly going to profit from any decisions we make along the way about what we prescribe. Mm-hmm. So we don't even think about it, which is, a very privileged way to practice. Mm-hmm. I am aware that across the country, there are places where medicine in general is kind of like the Wild West, and that the profit motive is evident at all aspects of the patient's care. And I think it's, very important for patients to be aware about these things and to think through about the options that are being recommended to them. But of course, in many cases, that's hard for them, So it might also be, from a practical standpoint, given what the question that you're raising, I think it's an argument for occasional second opinions about, if you come to a medical center and somebody recommends treatment X and you don't know too much about it, it seems like there are several options. You might want to go get a second opinion on the off chance that what's being offered to you is being offered for some other motive.
Mm-hmm. Another big trend in cancer medicine that doesn't apply to you, but I'm curious what you think the impact did, is the disappearance of private oncology practices. 2015 ASCO report noted declining interest among oncologists in private or solo practice careers. And since 2008, in a 2020 report, 1,700 private oncology practices had closed or been acquired by hospitals, merged, or reported financial struggles. And a lot of these have been bought up by just a very small number of integrated practices or integrative companies that both distribute drugs and own these practices. Is this something that you have tracked or been aware of? And do you think it's a good thing or a bad thing or somewhere in between?
Yeah, I mean, I think some of the, I think it's quite complicated. I think it's just a reality of the marketplace that in many areas there's concentration of medical care in general. And it's just the way capitalism works, that you get these more efficient processes with many physicians working for a single provider. I think in rural areas of the United States where so many people live, this could be a destructive process. I'm well aware that many community hospitals are shutting down, that overall surviving in this marketplace can be really challenging for, as you said, either solo practitioners or even small physician groups. There is no economy of scale there. And for lots of different reasons, I think that would be a hard thing to sustain. However, in certain communities, that's what was available. And the loss of that is a big negative impact on that community. To not have a local oncologist that you could go to get local care, but to have to travel significant distances in order to get it. I think it's problematic. And again, I think the decisions are revolving around, when people can meet their bottom line. And as I said, I think designing a perfect medical care system for the country as it currently exists, where people live, is a different question than what works financially for the providers of medical care around the country. They're clearly going to lose money in certain markets and particularly rural areas. How do we fix that? I don't know how you fix that. Sure someone's thought about it more than I.
As we begin to move toward a close, as you know, we at Commonweal have been involved for over 34 years doing something like 220 week-long retreats for cancer patients. And now we continue to do those online. And we have a Healing Circles global community that is reaching out around the world, doing Healing Circles work with cancer and other patients. We also have a website called Beyond Conventional Cancer Therapies, which you've been kind enough to advise us on. that is doing peer-reviewed summaries of about 100 of the complementary therapies, supplements, herbals, and so on, as well as repurposed drugs and all the rest. We also collaborate with ASCO, the American Society of Clinical Oncology, and with the Society for Integrative Oncology, which is the professional group. I should correct that. We collaborate with the Society for Integrative Oncology, which in turn collaborates with the American Society of Clinical Oncology on protocols for integrative treatment of different cancers. And many of the people in the Society for Integrative Oncology, the leadership, really is drawn from the leadership of major cancer centers across the country. So that's the kind of parenthesis. So the question I want to ask you, you've followed our work, you're aware of it. There's this whole body of work on integrative oncology. And the major cancer centers have responded, fortunately to a degree, since I published my book, Choices in Healing, over 20 years ago, when all of the integrative stuff was regarded as quackery. But now you have integrative treatment centers at many, if not most, of the major cancer centers. But those integrative treatment centers tend to be what I sometimes call integrative treatment light, like light beer, in that they will talk about diet, stress reduction, exercise, social support, imagery, visualization, meditation. In some instances, they will go Memorial Sloan Kettering, as far as specializing in a traditional Chinese medicine where there's really strong evidentiary basis. But on the whole, it has remained, even though there's been this rapprochement from quackery to integration at major centers with integrative therapy light, nonetheless, a lot of quite evidence-based and at least evidence-informed therapies remain really outside of conventional cancer medicine. And I know that's also driven by the profit motive and institutional things and sociology of knowledge. But to what degree do you ever even think about that?
Yeah, I mean, I think, I live in my own world, which is a long way from yours. Yeah. I think about those things when I hear, so many of my patients who, in their own way, are, seeking and using alternative forms of therapy, and they tell me about it, and they ask me how I feel about it. I'm generally supportive. I think we have our own approach to integrative therapy at Boston Medical Center with a pretty wide variety of things that are offered to our cancer patients that I think are sensitive to where they're coming from and supportive to them from where they're coming from. Every hospital's patient population will be different in that way. So I would say that, we actually have an acupuncturist on staff in our clinic as one example. We do yoga, all those sort of things, but they might be what you refer to as light. I would say that as an individual, I'm supportive of it. I think for a lot of busy practices that are just even trying to get the more basic support services available to their patients, be it regular social work, palliative care, the other things we've talked about, that it's a stretch to develop their own integrative cancer program, I think more likely it would be something where we would have to find something in the area that was available and that we could refer people to and let them know about. That would seem probably a better way to do it. Yeah, I'm not actually aware within the Boston area of what those other sort of programs would be. I wouldn't be surprised if they're around. But yeah, it's not something that over my long career that I've done. I haven't actually referred people. I've mentioned Commonweal a bunch of times, and I've told people about your website. But beyond that, I don't know of actual integrative cancer programs in the Boston area, and I should. So that probably says something about my allopathic background.
Well, you're also a little bit busy. Speaking of which, about how many patients do you see on an average day in the clinic?
Yeah, I'd say personally, I'm seeing 20, 22 patients. More of my patients are passing through because I work with a team of providers. So if something comes up with the other patients of mine that are coming through clinic that's unexpected, then there are more of them around, probably in the range of 30 plus a day. Mm-hmm. It's a lot of people.
Yeah. And I understand that your Boston Medical Center prides itself on the diversity of its staff and its fellows and its training programs and so forth. Is that correct?
Yes, absolutely. Yeah.
Coming toward the end, is there anything that I haven't asked you about or anything that you want to add to what you said that you just would like to be part of this wonderful record of a conversation between two brothers who've done parallel work for 30 some years in this?
Yeah. Well, I think the two of us probably have shared the fact that, facing a cancer diagnosis often brings out the strengths of people. They call on reserves that they might not have known were there. And I think they learn things about themselves and their family that, are somehow crystallized by the experience of having cancer. And I suspect both of us appreciate getting a chance to watch people as they struggle with this often miserable illness. It's terrible, but it's also periodically quite wonderful to get to know people during this pretty profound stretch of their lives. And I think what I always am impressed by is just how, in general, most people really can approach their own mortality and the misery of the particular illness in ways that just really impress me. Mm. So we come at it from very different. I think I'm at the trunk and you're at the tail, or I'm at the tail and you're at the trunk. We're seeing this illness from different perspectives, but I think in terms of our interactions with people, we probably share quite a bit of. It can be hard, but it's also quite a privilege to have a job like this. I'm looking at, I like this conversation that we just had because I am towards the end of my career. And it's given me a moment to pause and look back at what it's been like. And I'm glad I chose this career.
When you think about what it is in you that has enabled you to keep going in a very difficult profession all these years, what do you think is the source of your impulse to do this?
Yeah. Well, it's damn interesting. It keeps changing. And, I think to practice within an academic setting is particularly rewarding. I'm surrounded by colleagues, that are wonderful, and also, fellows and residents that are remarkable. And so there's that whole aspect of it, just constant interaction and chatter at both a personal and an intellectual level about what we're encountering. And then the other aspect of what I just talked about, to work in a hospital like Boston Medical Center is incredible, because you just never know who you're going to encounter next. They're coming from places that are so different than my own life story. I was essentially born with a silver spoon in my mouth, and I recognize that. I've been so fortunate in how our parents raised us and the education we got. And I spend my lives with people that have very different life experiences, but I'm still able to connect with them, and I hope offer them something. And the practice of cancer medicine is incredibly interesting. It's all of internal medicine, with all the challenges of many different illnesses that patients have when they also have cancer, and then all the variety of cancers, and sometimes really striking improvement and benefit from these new therapies. It's definitely enough to make you want to go back to work the next day.
When we were taking a walk on your last weekend trip out here a few weeks ago to see me, my wife Cheryl, our brother Steve, and his wife Sonia, and we took a walk out on the Bolinas Mesa to a bench not far from our house. And I asked you what you tried to do with your patients when in the, you're seeing 22 people a day, very short period of time. And I asked, what was it that you tried to do? And my memory is that you said to me, I try to be sure that they went to a lot of trouble to get here today. And I try to be sure that it was worth their while.
Yeah. I think a lot of care is nuts and bolts and, real specifics, and may not be all about the cancer care. There are a million other things going on. As I mentioned, they have a lot of other illnesses, and, part of what you want to do is just keep your stuff together and not drop the ball on the many different things that are going on with them in terms of their health, but also other things that might be happening as well. So I think most people arrive at a visit with a number of things that they can benefit from, whether it's information in general about what's going on with their health, or specific things that need to get addressed and fixed. There's almost always something. And I think the cancer doctor needs to have a pretty broad view of what's within the range of care they should be providing.
Maybe almost the last question.
We get pretty close to being primary care providers periodically. Yeah.
A late question. I know enough about you to know that even though you haven't talked about it, that what I believe you bring to every patient, indeed almost every person you meet, is just a kindness, and I would go so far as to say a compassion that is palpable. And I just have been reading studies we have on our website about the power of compassion in the patient-physician interaction, how much difference simple compassion can make. And I'm curious, I would say that a lot of people at Boston Medical Center treating the low-income community have to be driven by something other than finding the highest salary they could find. That there must be a pretty strong, I'm imagining, ethic of service and ethic of really wanting to make a difference for low-income people. So 2 questions. One is, to what degree, 3 questions. To what degree are you aware of that impact for yourself? To what degree do you talk about it with your residents and the other staff? And then the third question is, to what degree is that the ethos of the hospital as a whole?
Yeah. I mean, I don't think when you're going through your day-to-day routine, you've got, am I being compassionate enough? I think it's, hopefully we're compassionate. I think we're not always compassionate enough. I think there's all, you can have been doing this for a long time and still make all sorts of mistakes at all levels and not bring your best self to every interaction. So I do think that as an institution, and it is something we talk about with each other, that we're pretty proud of, of where we work. And if anything, I feel fortunate to treat this group of patients. It's such an interesting and varied group of people. And your assumptions about people, talk about micro biases and all those sort of things that are being talked about so much right now in terms of medical care. Yeah, we all have so many preconceptions about people when we walk in the room, when we look at them and they look a particular way, and we think we know them, but we often really don't know that person. And I think that's actually to have a job where you interact just regularly again and again and again in hopefully a caring way with people that are different from you and in many ways, often wiser and more experienced about the world than you are from their incredible life journey. That's pretty damn cool to benefit from those interactions. I get a lot of juice out of just interacting with such a range of people every day. It's, not just the particulars of their ethnicity or whatever country they came from, but just who each of these people are. And so, yeah, I think most people who work at Boston Medical Center are aware of what a special place it is.
Adam, thank you for doing this conversation with me. It's been a great joy. And I'm so grateful that you are my brother. I'm so grateful that you and our brother Steve and I have had a close, loving relationship all our lives, and that we were raised by Max and Edna, who cared about all 3 of us. And you talked about being born with a silver spoon. I think that a large part of that silver spoon was just being born into a caring family. Aside from the fact we were born into a caring family and we were given great educations, and thank God each of us tried to find a way to be of service.
Yeah.
So
each in our own ways. Yeah. Well, right back at you, Michael. Yeah. Thank you for asking me to do this. It's really been wonderful to chat with you about all this.